Hi, my name is Joe Montano, and I'm speaking today on Person-Centered Care, the Foundation for Audiology Practice. This is part of the ASHA Lunch and Learn series. Really happy to be here today. As a part of this, we have to present our disclosures. So I am a paid editor for a book by Plural Publication, Audiologic Rehabilitation, and unpaid, I am on the Hearing Education and Awareness for Rockers Advisory Board, the Hearing Rehab Foundation Advisory Board. I am part of the ASHA Board of Directors. I'm the Vice President of Standards and Ethics in Audiology, and I'm active in the IDA Institute. So, who am I? So I'm part of the American Academy of Audiology, part of ASHA. I'm part of the AAO. I'm part of the Hearing Loss Association of America, part of the Hearing Education and Awareness for Rockers Association, part of the HRF. I'm part of the IDA Institute. One of my favorite organizations is the Academy of Rehabilitative Audiology. So if you can see a trend there, I have a great emphasis in audiologic rehabilitation. I have a family. I'm an audiologist. I love rock and roll. I'm a teacher. I do some community theater. And Tom Waits is one of my favorite performers. And so why am I saying who I am? Why do you really care about that? The reason you care about that, I hope, is because as a person, as a clinician, this is what I do when I'm with my patients. So I am a reality in a patient's life. The patient is a reality in my life. And this is all part of patient-centered care. So we think of hearing loss very simply. You have a hearing test, you have hearing loss, you perform a hearing aid evaluation, you dispense a hearing aid, and everything's great. The person hears, no problems. But we know that that's not true. They can't hear when they're at the baseball games. Their wife says that, oh, you're still not hearing me. I can't hear in restaurants. I can hear people, but I don't understand. I don't want to wear these things. I'm going to put it in the drawer. So we're faced with a lot of issues when we come to hearing aids and hearing rehabilitation. So what's in a name? So what do we call this? Audiologic rehabilitation, oral rehabilitation, auditory rehabilitation, hearing therapy. So we have all of these names for something that we all do. Every audiologist does oral rehabilitation. So it's ambiguous. What is oral rehabilitation? So let me define a little bit about oral rehab. There's an abundance of definitions, and they vary significantly. Some stress the activities that are associated with rehabilitation. Others focus on the reduction of associated disabilities. So the activities that we frequently associate with oral rehab are things like lip reading and auditory training, the very therapeutic interventions. But the other idea, the idea of reduction of associated disabilities, we really focus on communication function. We've shifted in most of the definitions from traditional AR services, and now we really address the emotional and the social aspects of hearing loss. When we think back to one of the definitions that we lived with for a very long time, the original 1984 ASHA definition, it said that oral rehabilitation refers to services and procedures for facilitating adequate receptive and expressive communication in individuals with hearing loss. That's a very generic statement, but it's very true. Someone with a hearing loss is going to have some difficulty with the reception of sound and with perhaps even with the expressive part of communication, especially children who were born with hearing loss. What happened was that there was really a search for an audiological identity. So what happened, we established the special interest divisions. Part of the special interest divisions was Division 7, oral rehabilitation and its instrumentation. What happened with that when we started to look at the definitions of oral rehabilitation is that we put an article out in the ASHA magazine. That was before the leader. We had a beautiful little magazine called ASHA, and they used to have a column called Focus on Special Interest Divisions. So Special Interest Division 7 put together an article about oral rehabilitation. And what it basically said was, audiologic rehabilitation is audiology. Everything that we do as audiologists is part of the audiologic rehabilitation process. Then what happened was the World Health Organization. The World Health Organization in 1980 put out a paper called the Classification of Impairment, Handicap, and Disability. What happened there is that this WHO classification system began to influence the way definitions of oral rehabilitation occurred. J.P. Gagne in 1998 said that oral rehabilitation was to eliminate or reduce the situations of handicap experienced by individuals who have a hearing impairment and by persons with normal hearing who interact with those individuals. The World Health Organization has been very influential in audiology and speech-language pathology. Although when they developed the International Classification of Impairment, Disability, and Handicap, they weren't thinking about hearing and speech per se, they were thinking about all of the things that might affect an individual in their lifestyle. In 2001, they revisited this definition and they changed it from not just about impairment, disability, and handicap, but rather looked at body functions and structures and activities and participations. Rather, what the World Health Organization was talking about is what a person with a disease or disorder does do or can do, a more positive swing on the idea of impairment. So the World Health Organization now refers to it as the International Classification of Functioning, Disability, and Health, and we refer to it as the ICF. So if you think about function, we might have a health condition such as aging. As part of aging, we might have an impairment that could be hearing loss. As part of hearing loss, there may be some activity limitations. So we might not be able to hear well on the telephone, or hearing the television may be limited. If these limitations begin to affect how we function, it may result in something known as a participation restriction, meaning that we might not go to church, or we might not be able to work properly because we're not able to use the things that we did for our jobs. So activity limitation and participation restrictions essentially replace disability and handicap. Another part of the ICF is contextual factors. Contextual factors represent the complete background of an individual's life and living. So we can't just look at an individual's hearing loss, we have to consider their environmental factors, their personal factors, and the things that have an impact on their health conditions. It emphasizes environment and personal factors. 2001, ASHA came out with another definition of oral rehabilitation, and this was created by the Task Force on Audiologic Rehabilitation. And the task force was made up of audiologists and speech-language pathologists. And the definition that came out of that task force was that audiologic oral rehabilitation is an ecological, interactive process that facilitates one's ability to minimize or prevent the limitations and restrictions that auditory dysfunctions can impose on well-being and communication, including interpersonal, psychosocial, and educational and vocational functioning. The beauty of that paper in 2001 was that it actually delineated what the skills and knowledge were of audiologists and speech-language pathologists who both perform oral rehab functions. While the two professions are different, so are their responsibilities in the performance of oral rehab. In 2014, I had the goal to come up with my own audiologic rehabilitation definition. And the reason that I did that was that I wanted to emphasize the patient-centeredness of the services that we provide. So I came out with this definition that basically said that AR is a person-centered approach to assessment and management of hearing loss that encourages the creation of a therapeutic environment conducive to a shared decision process necessary to explore and reduce the impact of hearing loss on communication, activities, and participations. I'm not going to read the rest of it because that's the main part of the definition. So let's think about a person coming into our clinics. We go in, person comes in, and we look at the audiogram, we take a history, and we say something like, oh, I see that you've had a history of ear infections. And the patient may say, oh, yes, as a child. Oh, your audiogram says that you have a moderate to severe sensorineural hearing loss. Oh, really? Oh, look, you need to have 2 hearing aids, but don't worry, they're really invisible. What? And then that patient goes home, and husband says to her and says, so dear, how was your appointment today? And she says, I think I'm deaf. So what we're trying to do is to mix up our patients. We give them hearing tests, we show them audiograms, and what do they understand about them? Usually nothing. What we're trying to talk about now is transitioning how we approach the care in audiology. We historically have practiced under the medical model. In 1994, Sue Erdman, David Wark, and myself did a paper on service delivery models in audiology. We talked about the medical model and the rehab model. We've re-looked at this, and in 2014, Sue Erdman wrote a chapter in a book my book, that talked about the biomedical model and the biopsychosocial model. So if we look at the biomedical model, it's a top-down communication function. It's authoritarian. The clinician determines what the diagnosis is and what the treatment is. The clinician does something to the patient. It's disease-focused. The clinician knows what's right for the patient. And so it's not a bad model. It's a very medical model, but it's curative. So we follow the medical model. We say, if you've got a hearing loss, we've got to do something to correct your hearing loss. The biopsychosocial model, on the other hand, is sort of a horizontal communication. It's interactive and facilitative. Patients identify problems and decide the treatment together with the clinician. It's patient-focused. Patients' needs and perceptions are involved in determining what those goals are. So the key aspects of the biopsychosocial approach, well, we view the patient as a whole. We look at the process of observation, introspection, and dialogue, and that's how we will determine what the goals will be of our treatment. The clinical interview, in which the patient's narrative is allowed to unfold without interruptions, listening to what the patient has to say. Very, very important as part of the patient-centered care approach. The practitioner-patient relationship fosters shared and complementary communication and responsibilities. There's a mutual understanding of what the patient's narrative means, and we have to make sure that we understand and include their perceptions and their experiences. The major difference between the biopsychosocial and the medical model is that the patient is engaged entirely in the treatment process. So I've taken those terms biomedical and biopsychosocial, and I've created two terms that I think are very related to how we might practice in audiology. One would be something I refer to as the technocentric model, and the other one is the patient-centered model. If you look at this schematic here, we have a technocentric in the middle, followed by some of the services that we provide as audiologists. The idea behind the technocentric model is that we are technology-focused rather than patient-focused. In the technocentric model, the emphasis is on the technology, and that's what is very consistent with the medical model. We're looking at the hearing aid as something that's going to help the person hear better. That's the product. So in the medical model, in the technocentric model, we do an audiologic assessment. We focus on the audiogram. We talk about the nature and the degree of the hearing loss. We focus on the impairment. Hearing aids, levels of technology, hearing aid functions, options, mechanics. We do hearing aid orientation. We teach the patients how to use the instruments, take care of them, how to maintain them. We do real ear verification. We look at prescriptions. We look up how they perform. And then we talk about accessories. Technologically focused. Everything about that interaction is technology. In the person-centered approach, what we have in the center there is not technology, but rather the patient, the person, the individual. And as you see, this counseling that surrounds the person. So the counseling is really the heart and soul of what we do in the person-centered care. So in person-centered, the first part of person-centeredness is the patient story. We refer to this as the narrative. What we want to do here is we want to provide open-ended interaction, open-ended dialogue. The heart of the psychosocial model. If you ask a person an open-ended question, the information you will get is sincere, honest, and very different than asking yes and no questions. Did you have a hearing loss? Did you have ear infections? Were you dizzy? Did you have ringing in your ears? If you ask somebody, why did you come here today? Or what is the problem? You get a very different response. We want to encourage a dialogue. Well, the audiogram is very important to us, but it's not very important to our patients. So what happens frequently is that audiologists spend so much time going over the audiogram. I've done a lot of work with the Hearing Loss Association of America, and I can't tell you how many times I've presented a talk on understanding your audiogram, because no matter how many times we go over circles and X's and frequencies and decibels, really they don't have a good understanding about it. So what they want to understand is, what is it that happens when I can't hear? Why can't I hear? What is my functioning like? So we don't want to provide yes and no answers. We want to get an open-ended dialogue between the audiologist and the patient. Self-assessment is part of this evaluation. So I see patients all the time, and I no longer do audiological assessments. I only do oral rehabilitation and hearing aid fittings, which of course is part of oral rehabilitation. Every single one of my patients is given a self-assessment form. So I know this is very 80s, came out in the 80s, HHIE, the CPHI, all of these different self-assessment scales, but they're so valuable in finding information about the patient. So we have an audiogram that may say that a person has a mild to moderate hearing loss, but when we give them a self-assessment scale, we know what that mild to moderate hearing loss is doing to the patient. We know how it's affecting them. It's a very big, always interesting discussion when somebody has a mild to moderate hearing loss and shows that they have no hearing handicap, that they don't feel that they have any problem. And frequently my colleagues will say, well, they're in denial. But I really disagree with that. They're not in denial. What they're doing is living with their hearing loss, and this is their perception of how they live with their hearing loss. And it's our role to get them to understand hearing loss and their functioning. I use the HHIE, the HHIA, the CPHI, but there are an abundance of different self-assessment scales that are available for use. Communication strategies, always an important part of what we do in our rehab. Assessment of the environment, communication partnerships. Whenever anyone is with somebody with a family, I always invite them into every session. I also, if patients have come by themselves, I've always asked them to come back when we do the hearing aid dispensing with their spouse or children or grandchildren or friends, whatever. Sometimes, technology is certainly part of patient-centered, but we have to decide what hearing aids along with the patients, and we're not trying to be prescriptive. There are procedural components to AR. They're sometimes therapy-based. Sometimes we do speech reading, and sometimes we do auditory training. But most of those therapeutic interventions are now done online or computer-based. Two very common auditory training programs. One is the LACE that you've all heard about. Another one that I like is something called Read My Quips. Again, it's auditory training. It is online and interactive. It's very difficult for people to come back for oral rehabilitation in the therapeutic vein. One of the problems for us as audiologists is that we don't get reimbursed for those kinds of services. So if you have a speech-language pathologist who can get reimbursed for the services, it's great to be able to use them in that role. Person-centered doesn't mean that we're not going to be doing real ear and that we're not going to do verification or validation. Certainly very important part of every hearing aid fitting. And then we have consumer groups. We, at Cornell, where I am, we run oral rehab groups. We have new hearing aid user groups that we invite people in with their spouse. HLAA, we send people to our local chapter. And there's a lot of evidence out there about the effectiveness of group therapy. It's found to reduce hearing handicap. There are fewer hearing aid returns. There's research that shows that it improves quality of life, improves communication usage, strategy usage, improves relaxation. So it's not that we're just saying do groups, but there is actual evidence to show that groups are effective. So person-centered, we're juggling a lot of different aspects, but what's very important is that the patient is really the primary part of that process and not the hearing aid. So when I speak to students, I like to say that a hearing aid isn't the product, but we, as the audiologist, we're the product. We're the reasons that the patients are coming to see us, not the hearing aid. Bill Noble talked about the auditory reality. And that's the circumstances that make up a person's auditory life. Very important to understand how a person hears, where their communication takes place, how they function with their hearing aids. I did a photo essay presentation once where I followed a patient from exiting the taxi cab, coming into our building, going up the elevator, coming to registering at the desk, waiting for the audiologist, getting hearing aids for the first time, going back down, and then walking into the streets of New York City. Can you just imagine what that would be like for that individual? Brand new hearing aid on the streets of New York City? Tough. That's really a lot of noise. So we have to understand the environments that people live when we think about hearing aids. Know what it is that they do. Are they quiet? Are they active? Are they in business? Do they need to get the top of the line hearing aid for, all this thousands of dollars when basically what they do is they sit and they spend time with their family and they don't need to spend $6,000 when, maybe $1,500 will do a great job. So shared decisions. Something that we tend to do, but we don't think about it really. We tend to do, an audiologist, when somebody comes in to see me, I don't say, oh, you've got a mild to moderate hearing loss, you need X, Y, and Z hearing aid. So we talk. I find out their story. I say, what is it that you're looking for? How can we figure out what to do here? And together, you make a plan. So part of the shared decision process is that the patient is equally involved in setting the goals for their treatment. That is not typical of the medical model, but very, very typical of a patient-centered approach. If we think about shared decision in practice, the patient and the clinician must define the problem. Now understand, as a clinician, we look at an audiogram and we sort of predict what the problem is going to be. But you know what? We're not always right. Frequently, the patient has a very, very different perception of what that problem is. So it's together, the patient and the clinician work together to define what exactly the problem is. Do we both agree? And if we don't agree, let's discuss it and figure out where the medium is. So we want to negotiate the agenda. We want to figure out what are the goals that we want to set for this individual. We want to present the options. What are the positive things that can happen? What are the negative things that can happen? Some of the work that I used to do with the IDA Institute, they have a series called The Line, the Box, and the Circle. Well, the line was, how ready are you to obtain hearing aids? And the box was just a matrix that decided what are the pros and what are the cons of getting hearing aids. That's one of the things that you can do when you think about trying to figure out what are the goals that you're going to set. We want to explore what the patient values are, their preferences, what their concerns are, and what their expectations are. That's probably one of the difficult hurdles that we have to face. People have really unrealistic expectations about hearing aids, and I don't personally think that everybody needs to get a hearing aid. Sometimes people can learn to communicate very effectively, with mild hearing losses, and getting a hearing aid, if we sell them a hearing aid and they're not ready for it, the end result is that it's going to go in the drawer in the nightstand. So working together to help them get ready and understand what a hearing aid will do for them, that's our goal in rehab. We need to clear any of those misconceptions, and we need to include communication partners. If you ever have been with a spouse, husband and wife, in a situation where a patient is dragged in because they have a hearing loss and they're not ready to get a hearing aid, but the wife or the husband says, oh, this person needs the hearing aid, frequently what happens is we look at an audiogram and we say, oh, yes, you need a hearing aid, and you already immediately side with the spouse that's trying to get them to get the hearing aid. What you need to do in those situations is really encourage the dialogue. And so that's the challenge for us. So we don't just immediately look at the audiogram and say, you need a hearing aid. We need to understand the values that that person has with the hearing loss. So shared decision-making, the pinnacle of client-centered care, is asking clients not only what's the matter, but what matters to you. Understanding the lifestyle, the needs, and the preferences. Ensuring that clients understand treatment options and the possible outcomes, and engaging the clients in decision-making about the treatment and about the goals. So how can we do this? Critical elements of counseling. If anybody knows me, they know I always talk about counseling. When I'm asked, do you do hearing aid evaluations? I say, I take a counseling approach to hearing aid evaluations. To me, the audiogram never is as important as people think it is. To me, the dialogue is what's really important. So it's important that we listen to what our patients say, not look at an audiogram, say you have a moderate hearing loss, you need a hearing aid, but rather listen. Acknowledge that you're listening. Shake your head, support the person, let them know that they've been heard. Repeat some of the things that they've said. So when you can acknowledge that you've listened to what the person has said, you already begin to build a bond. You begin to have a trusting relationship, which is really very important if we're going to succeed, is that your patient trusts you as a clinician. Clark and English say you need to answer an affective statement with an effective response. So if somebody says something to you that is emotionally filled, you need to acknowledge those emotions. Trust. The more patients trust their healthcare providers, the more likely they will follow recommendations for treatment and continue doing business with them in the future. Chris English again. Patient trust practitioners when they perceive that we are technologically competent. That, for the most part, is already occurs when they walked in the door to see you. So they're assuming that part of that we have the competence to fit them with the hearing aids. When we acknowledge the patient's welfare, that they know that you've said something to them and you're not just trying to sell them a hearing aid, because there was an interesting study that took place in Australia. It was Louise Hickson's group, and they did a qualitative study where they interviewed people about who got hearing aids from audiologists, and there were statements that said something like they felt that they were at a used car salesman, that they felt that they were trying to be sold hearing aids, and really that's not what we should be doing. What we should be doing is trying to rehabilitate hearing loss. So we want to possess interpersonal competence, and communication, effective communication, is what builds trust. Lots of times people say to me, I'm in a busy clinic, I only have 30 minutes, I don't have an hour, I don't have enough time to talk to my patients, and I always say we need to really prioritize what it is that we're going to do. I've observed many audiologists working with patients when they're identified with hearing aids, with hearing loss, and they spend so much time going over the audiogram, going over the frequencies, going over, mild to moderate. It's really not as important as we make it out to be. That's for us. That's for us to understand what the function is, what the physiology is for this person's hearing. What we need to understand is how they function with it. So to me, it's much more important to have this dialogue from the patient as opposed to going over their audiogram. We want to assess what they need, what their functioning is, how we can resolve some of the problems. We want to limit the technology jargon. If you say, I've got a speech reception threshold of 15, that means absolutely nothing to somebody with a hearing loss. So we want to not talk about jargon, not audiology jargon. We want to respond to what they tell us. So the audiogram is less important in the process than we tend to realize. Counseling, who better to counsel a person with hearing loss than an audiologist? Sometimes people are nervous about dealing with the emotions. Don't worry about it. We have the knowledge. We know about hearing loss. Be able to understand what a person is going through, and you will build a relationship with that person right away when they know that you're listening to them. So let's have this happen. When you go to the audiologist office, you say, "Nice to meet you. What brings you here today?" And the patient says, "I've been having problems hearing my friends and family." "Oh, that must be difficult. What kind of problems?" "Sometimes I feel left out of conversations." "Oh, I'm sure that must upset you. Do you think that we might work together to find something," I can't read that, "to make it better?" And the person says, "I'm not sure what my options are." So that patient goes back to his wife and he says, "So dear, how was your appointment?" And the patient says, "I think my audiologist gets me." So the main message: patient-centered communication is the key to future hearing health care. Second message: technical skills are assumed. Interactional skills are valued. Communication is central to patient-centered care. So, just to conclude, think about what it is that you do in your office every day. Think about that patient that comes in to see you. It's a routine process for us, but it's a new experience for them. Ask them why they're there. Ask them why they're there. Ask them how they live with their hearing loss. And most important, listen to what they say and acknowledge them in your response. You'll find that you'll build a relationship of trust, and that really is essential to a good relationship with your patient. I'm happy to address any questions. You can reach me at Weill Cornell Medical College. My email address is jjm2003@med.cornell, cornell.edu. My telephone number is area code 646-962-5347, and I love talking about this. So if you want to give me a call, I'm happy to speak with you. Thanks very much. Enjoy your lunch.